All right, let's jump right in. We're stepping inside the pressure cooker of a surgical oral board exam. This is your consultant, Viva. The topic is upper GI emergencies, and you're in the hot seat. Let's get started. So picture this. For the next few minutes, you are the surgical consultant on call. It's 3 a.m., the hospital is quiet, and you are the final word on the life or death decisions about to come your way. You ready?
And there it is, the bleep that gets your heart racing. An unstable patient, massive upper GI bleed. This is that classic Viva opener. Now, the examiner isn't looking for a fancy differential diagnosis. They're testing one thing and one thing only. How are you going to save this patient's life? Right here, right now.
Your first words in this exam have to project calm, confidence, and a systematic approach. You're going to tell them you're starting with the fundamentals, initial assessment and resuscitation. You have to stabilize before you can investigate, every time.
You start with the mantra we all live by. ABC. Airway. Is the patient awake? Can they protect their own airway, or are they at risk of aspirating blood? If you have any doubt, you say I'd have a very low threshold to intubate. Breathing. What are their SATs? Get some oxygen on them. And C for circulation, this is where the real action is. This patient is in shock. So let's break down exactly what you're going to do.
So you rattle off these actions nice and clear. 2 large bore IVs, no question. You're sending off a rainbow of bloods, but the most important one is the cross-match. You're starting fluids immediately, something like Ringer's lactate. You're giving a big dose of an IV proton pump inhibitor. An NG tube helps decompress the stomach, and a Foley is non-negotiable. It's your best window into how your resuscitation is going. And finally, you order an erect chest X-ray. Why? Because you have to rule out free air from a perforation. That one simple test could completely change your next move, couldn't it?
Okay, so the patient is stabilizing. The free fall is stopping. Now, and only now, do you start pivoting towards a diagnosis. You've bought yourself some time. The gold standard investigation for an upper GI bleed. It's got to be endoscopy.
Your goal is to get this patient scoped within 24 hours. And when you do, the force classification is your roadmap. You absolutely have to know this table. It grades what the ulcer looks like, which tells you everything about the risk of it rebleeding. You see anything like a spurting vessel or an adherent clot, Forest IA, IB, IA, or IB, you know you have to intervene right then and there. So, based on what you find during that endoscopy, you've hit a major fork in the road. Can you handle this with the scope, or is it time to call the operating room? This is a core judgment call the examiner is testing you on. If you see those high-risk signs, your first shot is endoscopic therapy. You can try cautery, throw on some clips, inject a little epinephrine, whatever it takes to stop the bleeding. And if it works, great. You watch the patient like a hawk. But what if it doesn't? Well, the rule of thumb is pretty simple. You get 2 tries with the scope. If the bleeding comes back after you've stopped it twice, or if you can't get control in the first place, that's it. The next stop is surgery. In this slide right here, these are the hard stops. These are the absolute indications for surgery, and you should be able to recite them in your sleep. Massive hemorrhage you can't control. Bleeding again after 2 endoscopic attempts. Needing a ton of blood, that 4 units in 24 hours is a classic trigger. Or finding certain high-risk ulcers, like a big one on the back wall of the duodenum that's probably chewing into an artery. These are the patients you don't hesitate on. You take them to the OR.
So you've made the call. The patient's headed to the operating room. Now the examiner is going to grill you on the details. So, doctor, what operation are you planning to do? And your answer is going to depend on what you found and how sick your patient is.
Let's play out a classic high-stakes scenario. You've discovered a perforated duodenal ulcer, and despite everything you've done, the patient is still unstable. What is your go-to life-saving operation in this situation?
The answer is a Graham's patch. This is pure damage control surgery. The goal isn't a fancy, definitive repair. The goal is to get in, patch the hole, and get out, fast. You're just trying to get the patient off the table alive. You take a piece of omentum, lay it over the hole, and tack it in place. It's quick, it's effective, and it's absolutely the right choice for a critically ill patient.
But of course, not every case is a perforated DU. You gotta know the playbook for different situations. For a bleeding gastric ulcer, you really want to cut the whole thing out with a distal gastrectomy if you can. For a perforated gastric ulcer, you must biopsy it to rule out cancer. Then you can patch it if the patient's unstable or resect it if they're stable. And for those chronic, scarred-down ulcers causing an obstruction, the classic answer is a vagotomy and antrectomy.
And just when you think you're doing well, here comes the curveball. The examiner wants to see if you can think bigger. They'll throw in a little detail to see if you can connect the dots. This is where you can really stand out.
So the examiner says, by the way, the patient's history shows they've had this ulcer for ages and it just won't heal. That is a massive red flag. A stubborn, non-healing ulcer should scream one thing in your brain. Could there be an underlying cause? And the classic exam answer they're fishing for is Zollinger-Ellison syndrome, a tumor that's just pumping out gastrin.
The examiner leans in. Okay, doctor, you suspect a gastrinoma. Where are you going to look for it? This is just a straight-up knowledge question. Did you do the reading? Do you know your anatomy?
And the answer is the gastrinoma triangle, or Pissarro's triangle. You should be able to define its borders just like this. The junction of the cystic and common bile ducts up top, the neck and body of the pancreas medially, and the second and third parts of the duodenum down below. Knowing this little piece of anatomy is pure gold in an exam.
And the workup is pretty logical. First, you have to stop their PPIs, because those can mess with the test. A fasting gastrin level over 1,000, that's pretty much a slam dunk. If it's in a gray area, you do a secretin stimulation test to confirm. Then, you have to find the tumor with imaging. And critically, you need to screen for multiple endocrineoplasma type 1, or MEN1, by checking their calcium and PTH levels.
Okay, we've managed the emergency, we've thought about the rare stuff, and we've navigated the surgical options. To really nail this Viva station, you have to stick the landing with a crisp summary. Show the examiner you know what really matters.
So if you remember nothing else, remember these points. Always, always start with your ABCs. Use the Forrest classification to guide your hand. Know those absolute indications for surgery cold. Remember, Graham's patch is your best friend in an unstable perforation. A non-healing ulcer should make you think of a gastrinoma. And be ready to draw that gastrinoma triangle.
And that's our deep dive into the upper GI bleed Viva. But of course, the job is never truly done. What about what happens after surgery? Your patient recovers, goes home, but comes back weeks later with pain after they eat and vomiting up bile. What's on your differential now? Afferent loop? SMA syndrome? Well, that's a whole other topic for another day. The point is, you always have to be thinking one step ahead.